Okay, start ചെയ്യാം doctor.
Okay. First തൊട്ട് start ചെയ്യല്ലേ?
അതെ.
Hello. So today's class will be on ulcers. So an ulcer is a break in the continuity of the covering epithelium, either skin or mucous membrane. So an ulcer can happen anywhere on the body. And if you look at the image of this ulcer, we can identify the parts of an ulcer. So first we can see the margin of the ulcer. If you follow my cursor, I hope you can see the cursor. So the circumference of the periphery of this ulcer is called the margin of the ulcer. So it can come in any shape. It need not be always circular or continuous. It can come in any shape. So the circumference of the ulcer is called the margin of the ulcer. And the main bulk of the ulcer, what we see, or the main component of the ulcer, what we see here is called the floor of the ulcer. And the part that connects the floor to the margin is called the edge of the ulcer. So if you look at this image, the third image, you can see how an edge connects of the ulcer to the margin of the ulcer. So even this edge also can come in different shapes, and the entire ulcer rests on the base. Base can be any structure in the body. So we can see, look into different parts. Which is margin. It can be either regular or irregular. Then second, it can be rounded or oval. The important component of ulcer is its edge, because edge always helps us in identifying the type of the ulcer. It's having a lot of diagnostic importance. So edge is the one which connects the floor of the ulcer to the margin. So I hope it's clear from both the images. Now we'll see different types of edges. First is sloping edge. So sloping edge, if you look, it's the edge is sloping. It's sloping towards the center of the ulcer. So here, I hope you can see the cursor. Imagine this is the center of the ulcer, and this edge is directed towards the center of the ulcer from the margin. This sloping edge is having significance because a sloping edge always indicates a healing ulcer. So once an ulcer tries to heal, what happens is that the granulation tissues forms from the center to the periphery. So granulation tissues forming within the ulcer gives a typical sloping edge to the ulcer. A sloping edge indicates that the epithelium is going in from the ulcer edge in an attempt to heal itself. So second type of ulcer is undermined edge. So in the first type, so that healing was happening, and the edge is directed towards the center of the ulcer. Whereas in an undermined ulcer, we can see that the shape is exactly the opposite. This happens because the healing is not happening. In undermined ulcer, we can see that the edge is directed going away from the center of the ulcer. If this is the center of the ulcer, we can see that the edge is going away from the center of the ulcer. Whereas the margin is coming closer. The margin is trying to coming towards the center, but the floor is spreading outwards. This is happening because in the deeper planes, the ulcer is not at all healing. It's going into the deeper plane. It's proliferating, whereas margins are trying to heal. Healing is happening in the margin, so margins is trying to close. Here, the wound is trying to close from the level of margin, whereas in the deeper planes, this ulcer is not at all healing. It's spreading, or it's going into the deeper planes. I hope I'm clear. So that's how an undermined edge is formed. So undermined disease process advances in deeper plane in subcutaneous tissue level, whereas in the epidermal level, it proliferates inwards. In the epidermal level, healing is happening, whereas it's not happening in the subcutaneous tissue level. So this gives this characteristic undermined edge look. I hope I'm clear. Then the third one is punched out edge. So punched out edge, you can see that the edge is almost perpendicular to the floor of the ulcer. This indicates that there has been rapid depth the whole thickness of the skin without the body making an attempt to repair of the defect. Here, the body is not at all trying to repair. In the first image, in a sloping edge, we saw that that ulcer was trying to heal from the center, whereas in case of undermined edge, we saw in the center level, in the deeper planes, there is no healing tendency, whereas periphery was trying to heal. Whereas in a punched out edge, there is no healing process either in the level of subcutaneous, even in the level of deeper tissues, or at the level of epidermis. Yeah, the second image shows how a slopping edge is, how the margins are edges trying to heal. Whereas in a punched out, it's not present. This is a typical punched out edge. The next one is everted edge. So it is seen in carcinomatous ulcer due to spill of proliferating or malignant tissues of the normal skin. So here, here the ulcer is trying to heal, but it spills off because there is slight malignant tendency. Due to the malignant tendency, the active cells are spilling off. There is excess active cells, and it gives this characteristic everted edge because the granulation tissue or the cells which we're trying to repair spills out. The tissue at the edge of the ulcer is growing so fast that it overlaps the normal skin as it spills out of the ulcer site. Whereas the epidermis or the margins are not at all trying to do this, but from the inside of the ulcer, the proliferation happens, and that gives rise to the typical everted edge. So first we saw slopping edge. Slopping edge was usually seen in venous ulcers and healing ulcers. I told you that healing ulcers will have a slopping edge. Yeah, even the venous ulcers in the body will also have slopping edge. Next is undermined edge. Certain ulcers like tuberculosis ulcers and ulcer and Buruli ulcer has undermined edge. We'll look into detail about all these ulcers. So punched out edge is seen in trophic ulcers, diabetic ulcers, or any other neuropathic ulcer, and even in syphilitic ulcer. Everted edge, as I told, it's a feature of carcinoma. It's also seen in marginal ulcer. This marginal ulcer is having the tendency to become carcinomatous. That's why it has that characteristic everted edge. Then rolled out edge is a feature of BCC, basal cell carcinoma. So these are the main 5 type of edges, and these are the example of ulcers which are having this typical edge. So next, we'll move to the floor. Floor is the one which the structure that we see. Floor may contain discharge, granulation tissue, or even slough. So this is how the floor will look. In this ulcer, the majority of the ulcer is composed by the floor of the ulcer. So we can see different type of, we may see granulation tissue here, we may see slough here, or even it can be filled with discharge. So now we'll see what a granulation tissue is. So it is proliferation of new capillaries and fibroblasts intermingled with RBC and WBC with thin fibrin covered over. I hope you remember from the last class how a wound is healing. So we know ulcer is a kind of wound, right? So when a wound tries to heal, all these stages we have seen how fibroblast grows and makes a fibrin network in order for the healing to happen. So granulation tissue is an indication that the ulcer is trying to heal. So granulation tissue is we can see prolifered new capillaries, fibroblasts intermingled with RBC, WBC with thin fibrin cover over it. So granulation tissue typically grows from the floor of a wound and is able to fill wounds of almost any size. So however big the wound may be, granulation tissues help the wound to regenerate, the ulcer to fill up. So the bulk of, there's loss of tissue in ulcer, right? Ulcer is defined as a loss of the tissue, right? So this lost part is compensated by granulation tissue. So here, this is a typical granulation tissue. The first image shows how a granulation tissue is formed. This reddish pink structure, thing is called as granulation tissue. So if we look, we can see new blood vessels and inflammatory cells forming at the site of ulcer. So a healthy granulation tissue is characterized by its pink color, punctate hemorrhage, pulse fullness, painlessness, and pinhead granulation tissue. So these are the 5 pieces of granulation tissue. It'll be pink in color. Not exactly pink, but reddish pink. So pink in color. It'll have punctate hemorrhage. That punctate hemorrhage is like petechiae hemorrhage, similar to that. And it's pulseful. There will be pulse because we know new capillaries will be formed at the site. So pulseful. Then painless. Nerve endings won't be present, so it's painless generally. Usually it's painless. Then we can see pinhead granulation. Oh, that's a spelling mistake. It's granulation. So there will be pinhead granulation. So, and normally this might contain serous discharge. So this is a good granulation tissue, healthy granulation tissue with its slight pink color. But there is a chance of granulation tissue becoming unhealthy. If the granulation tissue is not healthy, if it is unhealthy, it won't be pink in color. Instead, it will have a pale color and the discharge will be purulent. It will be filled with purulent discharge, and most importantly, the floor will be covered with slough. The yellow thing that we have that we see is called the slough. So, and if we consider a non-healing ulcer, we can see in addition to the granulation tissue, the edge will be usually inflamed and edematous. So here in this ulcer, we can see how the floor is filled with slough. So this in order for the healing to happen, we have to remove the slough, and then new granulation tissue will start to form. So slough removing is an important part of ulcer healing. And then there is something called exuberant granulation tissue. It's not at all a healthy granulation tissue. It's one of the unhealthy granulation tissues. What happens here is it occurs in the sinus or an ulcer wherein granulation tissue protrudes out of the sinus opening or an ulcer bed like a proliferating mass. If the granulation tissue is growing out of proportion and if it's coming out of the ulcer, it's called as proud flesh or exuberant granulation tissue. So the image here shows a exuberant granulation tissue. This usually happens when a foreign body is retained within the ulcer. If a foreign body is retained within the ulcer or the sinus cavity, it can lead to proud flesh. The next is pyogenic granuloma. This is also one of the unhealthy granulation tissues. What happens here is that here granulation tissue from an infected wound or ulcer bed protrudes out and presenting a well-localized red swelling which bleeds on touching. This is an image of pyogenic granuloma. Now we saw, granulation tissue. And next, we know that ulcer bed can also cover discharges, right? The different types of ulcer discharge. And the significance of ulcer discharge is that we'll get to know about the ulcer also. Like how an edge helps us in diagnosing the type of ulcer, discharge also will help us in understanding the type of ulcer. So first, serous discharge, as I told earlier, it's a feature of healing ulcer. Whereas purulent discharge, if discharge is purulent, it indicates that some kind of infection is happening to that ulcer. It's not healing. Some kind of infection is happening. Some kind of organism has infected the ulcer. Third one is bloody discharge. Bloody discharge can happen in granulation tissue. One of the features of granulation tissue is that it might bleed. So bleeding discharge can be a feature of healthy granulation tissue forming in a healing ulcer. But if it's too much, it indicates that the ulcer has malignant feature. Even pyogenic granuloma will also have bloody discharge. Then CS discharge with sulfur granule is an indication of actinomycosis. If the ulcer is happening due to actinomycosis, then it will have sulfur granules within it. So the discharge will be serous with tiny sulfur particles in it. Third, last one is yellowish discharge. It's a feature of the ulcer. Purulent discharge, if the ulcer is infected with Staphylococcus, it will have yellow color. The discharge will be yellowish in color. And if the organism affecting is Staphylococcus, it will be usually bloody in nature, bloody and opalescent. If Pseudomonas is infecting, this is important. If Pseudomonas is infecting an ulcer, it can give a typical green color discharge, and green color is due to pseudocyanin present in the ulcer, in the Pseudomonas. So here these are the different types of ulcer and different types of discharge. This is a picture of how actinomycosis ulcer. Here, in the tissue paper, you can see sulfur particles, sulfur granule. And the last ulcer is a base. Base is on which the ulcer rests. It may be bone or soft tissue. The ulcer can rest either on a soft tissue or on bone. So what's the difference between floor and a base? Floor is the exposed part of the ulcer, and we can see that by inspection. Whereas base is a structure on which the ulcer rests, and that we cannot see, but we can feel it by palpation. So these are the four structures of an ulcer. So now the most important part of today's class will be certain types of ulcers. The first one is arterial or ischemic ulcer. First I'll list out a certain set of ulcers and we'll go into the ulcer. So arterial, venous, traumatic, ulcer. So all these ulcers we'll see in this class today. So the first one is arterial ulcer or ischemic ulcer. So it is due to poor supply of blood following blockage of the digital artery or any medium-sized artery. So we know if a artery is blocked due to any cause, it will lead to ischemia, and ischemia will lead to death of tissue. So that will lead to an ulcer. This is how an arterial ulcer will form. It's common in toes, feet, legs, or even in upper limb digit also we can see arterial ulcer. So atherosclerosis and KOs, thromboangiitis of obliterans, are the common causes of arterial ulcers in lower limb. Whereas in upper limb, most common causes are cervical rib, Raynaud's phenomena, vasculitis. We'll see about all these phenomena in the further classes. So these are the causes of arterial ulcer in lower limb and as well as in upper limb. So here, if you look at ulcer, we can see that ulcer initially occurs after trauma, soon become non-healing, spreading with scanty granulation tissue. Why is it this ulcer non-healing? Because there is no blood supply. So due to the absence of or blood supply or reduced blood supply, usually this ulcer is not healing in nature, and it will take some time for the ulcer to heal, even if it's healing. And this ulcer is very painful, tender, and offer high prosthetic. So intermittent claudication and rest pain are one of the important features of arterial ulcer. So arterial ulcer will usually have intermittent claudication and resting pain. Other features are like pallor, dry skin, brittle nail, patchy ulceration, and loss of hair. These features are happening due to ischemia. And other important symptoms of arterial ulcer is there will be resting pain and intermittent claudication. This ulcer will be very painful and will be very tender to touch. This is how an arterial ulcer will look like. Next is venous ulcer. Venous ulcer is also called as gravitational ulcer. So this ulcer is very common around gaiter zone. So gaiter zone means this is a gaiter. Like above shoe, what you see is called a gaiter. So gaiter is something that trekkers and all wear to prevent this moisture or water or dust entering into the shoes. So this area where we put gaiter is called as gaiter's area, and venous ulcer is very common in gaiter zone. Gaiter zone, please remember that picture of a gaiter so that it'll be easier for you to remember. So gaiter zone, where ulcers have mostly occurring in gaiter zone will be mostly venous ulcer. That's due to ambulatory chronic venous hypertension. Due to the stasis of the blood, it will eventually lead to breakage of the skin and ulcer formation. So it's due to most common and important reason is varicose vein happening to long saphenous vein or short saphenous vein or perforators, or even post-phlebitic limb. So for post-phlebitic limb is like post-thrombotic limb. So if a thrombus happens, we know how venous stasis happen. Even same thing happens in varicose veins also. So in both these conditions, we know like venous blood stasis is there, which will eventually give rise to a tissue injury, which eventually lead to ulcer. So this ulcer is also very painful initially, but later as it becomes chronic, it becomes painless. Ulcers are often vertically oval, never above the middle third of the leg. I hope you remember gaiter zone. So it usually happens only in gaiter zone or even below that, but it usually never happens above the middle third of the leg. It's happening towards the lower parts of the leg. Floor is covered with pale or often without any granulation tissue. When well granulated, edge is sloping, because when well granulated means that ulcer will have a healing tendency. Once healing tendency is there, we know edge will be sloping in shape. So induration and tenderness is often seen at the base of the ulcer. Venous ulcer is vertically oval with sloping edge and will not penetrate deep fascia, because venous ulcer has a tendency to heal soon. So penetration is not a common feature of venous ulcer. Inguinal lymph nodes are often enlarged. Ulcer often attains very large size, which is non-healing, indolent, and callous. Ulcer heals on rest and treatment, but reforms again and again. So this is an important feature. This ulcer has a tendency to heal, but what happens is that it will come back. It has a tendency to come back because the cause is still, if the cause is still remaining, if the varicosity is still remaining, or if the cause is still remaining, it will come again. So this will lead to scarring, and the scarring might lead to marginal ulcer. Marginal ulcer is a type of ulcer that originate from a pre-existing ulcer, pre-existing scar. We know that scar has a tendency to become malignant. So that lead to squamous cell carcinoma, which is known as malignant ulcer. So this is also an important point to remember. Marginal ulcer usually originates from a pre-existing scar. Marginal ulcer is a type of squamous cell carcinoma. This is a gator, and this area where a gator is born is called as gator zone. And this is a stasis ulcer or a venous ulcer. So please keep the location of the venous ulcer in mind. Whereas, third type of ulcer is neuropathic ulcer. Neuropathic ulcer is one that occurs as a result of peripheral neuropathy. And there is a loss of protective sensation in peripheral neuropathy. We know when peripheral neuropathy happens to a person, they have diminished sensation. The sensation will be diminished. And so even if a wound happens to that patient, the patient won't understand because there is absence of pain, absence of sensation. So due to the loss of protective sensation in peripheral neuropathy, repetitive stress and unnoticed injuries forms, and that will result in painless ulcers forming on the pressure points on the limb. So wherever the pressure points, so we all have the tendency to form tiny injuries in our body, but normally what happens is that we'll understand that injury has happened. We'll have a sense of pain and we'll take care of the wound. But if a person is lacking that sense of pain, or the sensation is little lost, what happens is that they'll unnotice the wound, and the tendency for it to form into a big ulcer is very high. So such a thing is called as neuropathic ulcer. So peripheral neuropathy diminishes the sensation, and that will lead to tiny injuries, and it can lead to painless ulcers, especially on the pressure points of the limb. So the most common cause for a neuropathic ulcer is diabetes mellitus. The second most common is vitamin B12 deficiency. So these two you have to keep in mind. The first most common reason for a neuropathic ulcer is diabetes mellitus, whereas the second important reason is vitamin B12 deficiency. In addition, peripheral vascular disease can also contribute to neuropathic ulcer. Even food deformity can also eventually lead to neuropathic ulcer. So these are the four important causes of neuropathic ulcer. The first two, diabetes mellitus and vitamin B12 deficiency, are very important. These two are the most important causes for a neuropathic ulcer. Diabetic ulcer, diabetic neuropathy is due to, why diabetic neuropathy happens. So it happens in diabetes is that the conversion of sugar to sorbitol happens excessively in diabetic neuropathy, and that sorbitol gets deposited to the nerves, and that will lead to demyelination. Sorbitol level rises, it gets trapped in peripheral nerves. So in diabetes mellitus, sugar get converted into sorbitol, and the sorbitol will get deposited or trapped in peripheral nerves, as well as in retina and lens, and these will lead to neuropathy. If it's in retina, it will lead to cataract. If it's in lens, it will lead to retinopathy. So these are the reasons for this is the reason for neuropathy in diabetes. So, this is one reason for ulcer in diabetes. One more contributing reason is increased glucose in the tissue precipitate infection. We know having high glucose content always precipitate infection, and this becomes the second reason for ulcer formation in diabetes. The third reason is diabetic microangiopathy. We know we learn in detail about diabetic microangiopathy, and due to microangiopathy, circulation will be deficient to the area, and hypoxia will be again one more important reason for tissue injury. So all these reasons together will contribute to wound formation and ulcer formation. One more reason is glycosylated HB. So here microcirculation is there already. Oxygenation is very poor. In addition to that, glycosylated HB carry very less oxygen. So all these factors contribute to a wound, and it will eventually become a big ulcer. Most common location for diabetic ulcer is food, especially in the plantar aspect. This is the most common location of a diabetic ulcer, and then it can also happen in leg, upper limb, back, scrotum, perineum, and I told how ischemia is happening in a diabetic ulcer due to microcirculation. Then ulcer is usually spreading and it's deep. Because of the above mentioned reason, the ulcer usually grows very deep. So if we differentiate between the three ulcers, venous ulcer, we know it it commonly occurs above medial or lateral malleoli in the gator zone. So if the ulcer is occurring in the gator zone with the healing tendency, it's usually venous ulcer. Whereas arterial ulcer often affect toes, digits, or even shin. Shin is also one common area for arterial ulcer, but it's mostly seen in toes as well as in digit. Then third, neuropathic ulcer, it has a tendency to occur on sole of the foot, especially on the pressure points. So this is how we can differentiate between arterial, venous, and neuropathic ulcers. Next is trophic ulcer. Trophic ulcer is pressure sore, or it's also called as pressure sore or decubitus ulcer. The word trophic is derived from Greek word trophy, which means nourishment. Ulcer due to impaired nourishment to the part. Pressure sore is due to necrosis and ulceration due to prolonged pressure. So if a patient is being in a position for a prolonged time, as in case of bed sore, we know that a patient will be in the same position for a prolonged time. So here the blood vessels will be jammed, and the chance of blood reaching towards to certain areas will be diminished, and this lack of nourishment to the area will lead to death of tissue and will lead to ulcer. So here the word trophic, if you can remember, that will help us in remembering about this ulcer. Trophic ulcer is pressure sore or decubitus ulcer mainly. Due to lack of nourishment to a certain area, the that tissue will have a tendency to ulceration, and that type of ulcer is called as trophic ulcer. So 30 mm of Hg, this keep in mind that capillary occlusive pressure is 30 mm of Hg. So if we give a pressure of more than 30 mm of Hg, mercury to a part, sustainably, that will lead to prolonged tissue hypoxia, which lead to ulceration and necrosis. So if the external pressure more than 30 mm of Hg is continuously given, that will lead to tissue hypoxia. It will eventually lead to necrosis and ulceration. So this is how ulcer takes place. It is more prominent between bony prominence and external surface. So these are the causes for trophic ulcer. First is impaired nutrition, defective blood supply, and neurological deficit. Normal stimulus to relieve the pressure is absent in anesthetized patient. The nutritional deficiency is worsened in necrosis. Inadequate padding over the body prominence in malnourished patients. Then urinary incontinence in paraplegia patient causes skin soiling, maceration, infection, necrosis. So this is what happened in case of a bedridden patient. We know if a bedridden patient is kept in the same position for a very long time, what happens is that blood flow won't be proper to the bony prominences especially, and that will lead to hypoxia and death of tissue. In addition to that, we know in case of bedridden patient, normally nutritional deficiencies can also happen. And if soiling is also present, it can lead to tissue maceration, infection, and necrosis. So all these factors contribute in the formation of a decubitus ulcer. Initially, it begins as callosity. Callosity means thickening or hardening. So initially, what happens is body tries to harden the area where body is constantly exposed to, or which comes in touch with, and due to that lead to suppuration. So there will be a callosity, and under which suppuration will happen, and eventually the suppuration will come through the callosity, and that's how an ulcer is formed. Here, so important things are impaired nutrition, defective blood supply, and neurological deficit. In an exam point of view, one important question they ask is the areas where decubitus ulcer usually happen. So just keep this image in mind, and we can see here the areas are back of the head and ears, shoulder, elbow, lower back and buttocks, heel, inner knee, hip. These are the most common areas where when a patient is bedridden for a prolonged time, where the patient is exposed to, or where the pressure is mostly exerted. So in this area, gradually the padding will go off, muscle atrophy will happen, and due to the pressure, hypoxia will happen, and ulceration can happen. In addition, if soiling is there, or if the patient is having urinary incontinence, soiling can also happen. So all these factors will contribute, and that will lead to a death of tissue. Common site are overaxial tuberosity, sacrum, heel. Then in relation to head of metatarsal, buttocks, over the shoulder, and occiput. These are the most common location where decubitus ulcer can be seen. So for a pressure sore, these are the stages of a pressure sore. First, there is superficial ulcer, and then it will become deep ulcer. A superficial ulcer can be again categorized into early superficial ulcer and late superficial ulcer. So if there is non-blanching erythema, that's a very first stage. So if a bedridden patient is having non-blanching erythema, we should keep in mind that it will have a tendency to become into a big ulcer. So if a non-blanching erythema is only present, that's a stage of early superficial ulcer. If partial thickness of skin is lost at any point, we can call it a late superficial ulcer. And if it goes further, we can see, and if the full thickness of the skin is lost to the extent of subcutaneous tissue, then it is called an early deep ulcer. And if the fascia is also involved, if there is loss of full thickness of skin till fascia and underlying structures like muscle, tendon, bone, etc., then it becomes a late deep ulcer. So these are the 4 stages of pressure sore. In 5% of all hospitalized patients, chance of decubitus ulcer is there. Then it's painless in nature, and it's usually punched out in shape. So please keep in mind that decubitus ulcer is punched out in shape and it's painless. The ulcer is non-mobile with base formed by a bone, because gradually it will reach up to the level of bone, and the base will be usually a bone. Due to the presence of neurological deficit, trophic ulcer is also called as neurogenic ulcer or neuropathic ulcer. Bed sores are examples for trophic ulcer. So neurological causes are diabetic neuropathy, peripheral neuritis, tabes dorsalis, spina bifida, leprosy, spinal injury, paraplegia, peripheral nerve injury, and syringomyelia. Next important ulcer is Martel's ulcer. So this ulcer is seen in hypertensive patients. So we saw how there's a chance of forming ulcer in diabetes patient, but here there's an ulcer which is commonly formed in hypertensive patient with atherosclerosis. It's seen in calf, often bilateral and painful. So I'll show a photo. So this is how a Martel's ulcer will be shaped. It's usually seen in the calf. Like if an ulcer is seen in the calf and it's bilateral, and if the patient is hypertensive, there's high chance that's due to Martel's ulcer. So Martel's ulcer pathology is atherosclerosis, which leads to death, hypoxia, and death of tissue. So necrosis of the calf skin occurs with sloughing away and formation of deep punched out ulcer extending into the deep fascia. So punched out shape is important. Then there is sudden obliteration of the arterioles of the calf skin. All peripheral pulses will be present. Then it takes months to heal. So here important feature is that it happens in hypertensive patient with atherosclerosis, and there is punched out appearance of the skin. These are the 2 important features, and also it's mostly bilateral, not always, mostly it's bilateral, and it's very painful. Next, a similar name, this was Martel's ulcer, and next is Marjolin ulcer. So Martel's ulcer, as I discussed earlier, it grows from a locally malignant lesion. So unstable scar of long duration can lead to squamous cell carcinoma, that is Marjolin ulcer. So Marjolin ulcer usually originates from a scar of long duration. It's commonly seen in chronic venous ulcer. When we discuss venous ulcer, we discuss this point. A venous ulcer has this tendency to heal and then again break out, healing, breaking out. So when this happens for a long time, definitely scar will be there. And this scar of long duration has this tendency to become malignant. And if a squamous cell carcinoma is formed from the scar, it will be usually Marjolin's ulcer. It's called as Marjolin's ulcer. So in addition to chronic venous ulcer, it can also come from a burn scar. And even a snake bite, previous snake bite. Both the snake bite as well as burn can lead to, healing usually happen by scarring, right? So when a healing happens in these burns as well as in snake bite by scarring, there's a slight chance that eventually it might lead to a squamous cell carcinoma. This is a burn scar. It was a burn scar, and I hope you can see how it has become that small ulcer. And this is a Marjolin ulcer. It's not, it's a malignant ulcer, so it has to be removed. So it's malignant ulcer. Keep in mind that marginal ulcer is one of the ulcers that has malignant capacity. Here, as we discussed in the edge session, being malignant in nature, the edge is everted because tissues will proliferate. So here, edge is usually everted in shape. It's usually painless because scar does not contain any nerve fiber. We know that. And due to the absence of nerve fiber in a scar, this ulcer also won't have a nerve ending, which makes it painless. It does not spread into lymphatic because scar is also devoid of lymphatic. And due to the absence of lymphatics, it do not spread by lymphatic. And induration is felt because of malignant property. Induration is felt at the edge and the base. There is marked fibrosis also. Then once lesions spread into adjacent normal skin, it can spread into regional lymph node, behaving like a squamous cell carcinoma. So unless it's spread to normal skin, it won't spread by lymphatics. But once it's spread to normal skin, it will behave like a squamous cell carcinoma. Next is normal carcinomatous ulcer. How a normal carcinomatous ulcer will be like. So it arises from the prickle cell layer of the skin. This is important. It arises from the prickle cell layer of the skin. It may initially begin as nodule or an ulcer, but later it forms an ulcerative lesion with rolled out or reverted edge. We discussed that rolled out or reverted edge are feature of malignancy. So carcinomatous ulcers of any nature will have a rolled out or reverted edge. So when we see a patient with an edge that has everted tendency, there is chance that it might be malignant. And here, due to the non-healing nature, usually floor will contain necrotic content, unhealthy granulation tissue, as well as blood. While discussing about discharges, we told that bloody discharge is a feature of malignant ulcer. Then ulcer bleeds on touch and it's vascular and friable. Then induration is felt at the base and edge. Induration as well as everted edge or rolled out edge are features of malignant ulcer. Please keep that in mind. Induration and this tendency to proliferate cells at edge is very dangerous. So this is how a malignant ulcer will look like. Here we can see how the edge is proliferating and it has a typical rolled out look. Yeah. And while palpating, it's always the induration can be felt. I hope you can see slough also in the ulcer. Next is tuberculous ulcer. So tuberculous ulcers happen due to Mycobacterium tuberculosis. It's usually due to cold abscess later forming ulcer in the neck, chest wall, and axilla groin. So we know in case of tuberculosis, there is chance of cold abscess formation, right? So cold abscess is an important feature of TB. And here, when a cold abscess is formed in the neck, chest wall, axilla, or groin, what happens is that later it might turn into an ulcer. So, and that's called as tuberculous ulcer. So here, this ulcer can be either multiple or single, and the shape also can vary from being oval to being rounded. But the important feature is that tuberculous ulcer is always undermined in shape. Here, as we discussed during the edge session, here the healing will happen at the level of epidermis. At the level of skin, we can see healing, but whereas a deep inverse ulcer will be always going deep and deep. That gives it this typical undermined edge. And this will be painless. Case-etching material can be seen on the floor. Ulcer is usually not very deep and regional lymph node can be enlarged and matted, firm and non-tender. So here, a TB ulcer, the important feature is the shape of the edge. TB ulcer is having an undermined edge. That you have to keep in mind. TB ulcer is having an undermined edge. So this photo, if you can remember, it will be easier for you. I hope you can appreciate this concavity at the edge. Here, the margin is trying to regenerate. Margin is trying to come together, and it's trying to close. Whereas deeper we can go, this we can see this ulcer is going deep and deep. That gives this concavity, and that's the undermined edge. TB ulcer is usually painless except when it comes on the tongue. So this is also very important. TB ulcers are usually painless, but when it comes on tongue, it's painful. That's TB ulcer. And one more organism coming in the TB family is another ulcer, that's Buruli ulcer or the Bainsdale ulcer. I hope you know the term Buruli ulcer. Buruli ulcer is also called as a Bain's-Dale ulcer. So here, this is a chronic irregular undermined ulcer due to Mycobacterium ulcerans. Mycobacterium ulcerans comes in the same family of TB. And here, deep, severe form of ulcer. This is with extensive dermal necrosis called as Buruli ulcer. Here, the bacilli is all, of course, acid-fast bacilli. And the line of treatment is anti-TB therapy. Why I told is because TB and Buruli ulcer are caused by bacteria from the same family. So one thing that they have in common is that both of these ulcers will have an undermined edge. And this is also mostly seen in tropical countries like West Africa and Australia. And large ulcers usually develop on the arms and leg. Edge is undermined. This undermined nature is seen in Buruli ulcer as well as in TB ulcer. These two ulcers, you have to remember, these two ulcers are caused by organisms from the bacteria from the same family, and both of these are having undermined edge. What happens here is that initially it starts like a small bump, like an insect bite. It will initially look like an insect bite, but later it will start to indurate and it will enlarge. Enlargement and induration will happen. Eventually, this will become a big ulcer. So here in this ulcer, I hope you can see the undermined nature. Here the margin is, here the floor is deeper. Floor is going, extending into deeper levels, whereas edges, margin is not. So just keep in mind this ulcer starts with a small insect-like bump and it will enlarge into this ulcer. That's Buruli ulcer. Buruli ulcer and TB ulcer are so similar. The difference is just that both are caused by the bacteria from the same family. Next is tropical ulcer. Name indicates it's seen in tropical countries. So tropical ulcer, more commonly known as jungle rot, is a chronic ulcerative skin lesion thought to be caused by polymicrobial infection. So it's not like one single organism is causing the infection. It's polymicrobial. So many organisms are, thought to be causing this disease. It's common in tropical climates. Ulcer occur on exposed part of the body, primarily on the anterolateral aspect of the lower limb, and may erode muscle and tendon, and sometimes even the bone. The lesion may frequently develop on pre-existing abrasion or sore, sometimes beginning from a mere scratch. So this happens in tropical country where people walk barefoot. What happens is that initially, if they have a tiny scratch or something on their leg, that can, and if polymicrobial infection happened to that area, that can lead to ulcers. That's tropical ulcer. In an acute ulcerative lesion of the skin observed in tropical regions like Africa, India, and South America, it's associated with lower socioeconomic group, anemia, malnutrition, and vitamin deficiency. So, as I told earlier, if any abrasions or tiny scars are present in the lower extremity, if the patient is exposed to these certain microorganisms, that can lead to a wound, right? And this wound can become an ulcer. And it's mostly seen in people with low socioeconomic background. So the most common organism behind tropical ulcer is Fusobacterium fusiformis. That's Vincent's organism, and or Borrelia vincenti. These two organisms are mostly behind this tropical ulcer. So it's the most common location of a tropical ulcer is in the lower limb, and it mostly originates from a pre-existing scratch or abrasion. This is how this tiny abrasion will become into such a big ulcer due to the presence of these organisms. It's mostly seen in tropical countries, and especially when people walk barefoot and they are exposed to certain organisms. So now we saw Buruli ulcer and tropical ulcer. Why I'm comparing these two is because both these ulcers are seen in tropical countries. So here, if we compare between these two, tropical ulcer is always painful, and it happens in lower limb. But in addition to that, when a patient is having tropical ulcer, what happens is that there will be generalized symptoms like fever, weakness, and everything. So it's a systemic, it looks like a systemic illness, and inguinal lymph nodes will also be involved. Whereas a Buruli ulcer, which also happens in a tropical area, will be on the lower limb, but it won't be having much pain. There won't be inguinal lymph node involvement, and even systemic symptoms like fever, chills, nothing will be there. So tropical ulcer is more of a systemic illness, whereas Buruli ulcer is little more localized. Undermined edge is a typical feature of Buruli ulcer, which won't be seen in tropical ulcer. And lower limb is the site for both. So that's the difference between Buruli ulcer and a tropical ulcer. Next is rodent ulcer. So it's an ulcerative form of basal cell carcinoma, which is common in face. So I hope you can see the ulcer here, just next to here. And I'm sure you all know the location where BCC happens. BCC usually happens above the, if there is an imaginary line between the angle of the mouth and earlobe, and usually BCC happens above the line. Most common location is face. Ulcer shows central area of dry scab with peripheral raised activity and beaded white appearance. Beaded white appearance is a characteristic feature of BCC. It's not in many other ulcers. So BCC has this typical beaded white appearance. Pearly white edge. Beaded pearly white edge. That's due to the excess activity of the margin cells in the margin. And this excess proliferation of cells gives that characteristic beaded appearance. Often the floor is pigmented. It erodes into deeper planes like soft tissue, cartilage, and bone. Hence the name rodent ulcer. It's like a rodent. It erodes into the deeper planes. So that's why it's called a rodent ulcer. Rodent ulcer is a very old term. Nowadays it's not used. Usually it's called BCC. As lymphatics are blocked early in the disease by large tumor cell, it does not spread to regional lymph node. Blood spread is also absent. So we can say that rodent BCC is locally malignant. It does not spread through lymph node or blood vessels. It only spreads locally. It's the common location is face. Rarely can occur over tibia, external genitalia, mucocutaneous junction. It does not occur in mucosa. Next is melanotic ulcer. So we know melanocytes in the skin. So melanocytes give rise to melanoma, right? So skin cancer or melanoma, usually it does not ulcerate, but when it ulcerates, it's called as melanotic ulcer. So it's an ulcerative form of melanoma. Usually melanoma is not, I mean, it need not be ulcerative, but if it's ulcerative, it's called as melanotic ulcer. It can occur in skin as de novo or in a pre-existing mole. It can happen as, I mean, it can start as a mole itself, sorry, ulcer itself, or it can it can ulcerate from a pre-existing mole. So if a pre-existing mole is having malignant properties like itching, color change, then what increase in the size, it can become a ulcer. Ulcer is pigmented, often with a halo around. Ulcer is rapidly growing, often with satellite nodules and in-transit lesion. It's very aggressive skin tumor arising from melanocyte. It spreads rapidly to regional lymph nodes. That's the difference between BCC and a melanocytic ulcer, sorry, melanotic ulcer. So this melanotic ulcer is due to its origin from melanoma. It's rapidly spreading. It spreads to lymph node. Even it spreads to blood, to liver, lungs, brain, bones. So the spreading nature is very common in melanotic ulcer, whereas BCC does not spread through lymphatic system or blood vessel. It only spreads locally. So even it can also occur in mucosa genitalia and even eye. So this is a melanotic ulcer in the foot with enlarged inguinal lymph node. In the first photo, the ulcer is shown. I hope you can see the characteristic pigmented or black color halo, or here this black color is there. So this is a feature of melanotic ulcer, and even this pigmentation also you can see. Here enlarged inguinal lymph node is also seen. This lymph node enlargement is due to it spread through lymph vessels. Next is Melanese ulcer. Melanese ulcer is also called as postoperative synergetic gangrene. So as the name indicates, it originates from a postoperative wound. So especially in people, old age people, as well as in immunosuppressed people, what happens is that there's this slight chance of post-operative wound to become gangrenous again, and that type of ulcer which originated from a post-operative wound is called as Melanese ulcer. It's commonly seen in post-operative wound in abdomen and chest wall like empyema drainage or after surgery for peritonitis. So the most common location is abdomen and chest. It is acute, rapidly spreading ulcer with destruction and deep burrowing of subcutaneous tissue. It's common in old age and immunosuppressed individuals and after surgery for infected cases. So immunosuppressed individuals are having this chance to develop a Melanese ulcer, and even old age people. And the organisms behind this are Staphylococcus and Streptococcus aureus, and even anaerobes are also capable of producing this ulcer. So Melanese ulcer or post-operative synergetic gangrene. It originates from a post-operative wound, and the most common locations are abdomen and chest wall. And it's rapidly spreading also. Texas Basin's disease. I hope you know the basin. You have heard this name, Basin's disease. It's also called as erythema induratum. Erythema induratum is a much more common term. So it's localized area of fat necrosis with chronic ischemia of angle skin affecting exclusively adolescent girl. So fat necrosis is a very important term that you have to remember when you hear Basin's disease. So Basin's disease is seen especially in adolescent girls who are little on the heavier side. Here around the region of ankle, fat necrosis happen, and this fat necrosis lead to ulceration, and that's Basin's disease. It's observed in girls with more thick subcutaneous fat around ankle. In these patients, perforating arteries perfusing skin around the ankle are small, poor, or non-existing that lead to ischemia. So due to the presence of thick subcutaneous fat, the perforating arteries around the skin will get obliterated or they're non-existing. And due to these reasons, there is a chance of ischemia around the ankle, and that will lead to an ulcer. And one important feature of this ulcer is that they'll be sensitive to temperature variations. When it's either too cold or too warm, they'll be sensitive to temperature. It's characterized by recurrent clusters of erythematous tender subcutaneous nodules with or without ulceration. So ulcer is not always seen in such cases. So erythema induratum is a better term. Can happen. Ulceration may or may not happen. So here, if you look at this photo, you can see how indurated areas are formed in the first image. In both the legs, you can see indurated hyperpigmented areas. In the second image, you can see how an ulcer has formed from such an area. One thing is that it's due to fat necrosis. Second thing is it happens exclusively in adolescent girls. Then it's due to obliteration of the perfusing arteries around the area. Then it's temperature sensitive. Sensitive for temperature alteration. And this is how it looks like. And finally, we'll learn Wagner's grading of ulcer. So Wagner has graded ulcer based on how much it has invaded. So grade 0 means it's a pre-ulcerative lesion or a healed ulcer. If an ulcer has completely healed, we can call it a grade 0 ulcer. Grade 0, we can categorize it into grade 0. And it's pre-occlusive, pre-ulcerative lesion also, we can call it as, we can categorize it into grade 0. If it's grade 1, superficial ulcers can be put into grade 1. Ulcers deep into subcutaneous tissue, exposing soft tissue or even bone are called as grade 2. So grade 2 is not mild. Grade 2 becomes very serious because we can see bones are exposed in this ulcer, or even soft tissues are exposed in this ulcer. It reaches up to deeper till subcutaneous tissues, or even up to bone level. Exposure will be there. Third is abscess formation can happen, or even osteomyelitis can happen. So grade 3 becomes so severe because osteomyelitis is there. Grade 4, what we can see is gangrene of the part. Gangrene is depth of tissue, so complete depth of tissue or a limb or a foot can be seen. Whereas last grade, that entire area or an entire foot will be affected. So grade 5 means entire foot. So grade 0, 1, 2, 3, 4. From 2 itself, we can see how bones are exposed. If bone is exposed, it becomes grade 2. Grade 3, we can see abscess formation or osteomyelitis if bone is the base. Then 4, in fourth grade, we can see in gangrene formation of the entire region. That region will be changed into a gangrene. But if the entire foot or if the entire area affected has been is becoming a gangrene, that becomes the fifth grade. So that's all regarding today's class. I hope I'm clear. So we saw the parts of the ulcer. Important thing is the types of edge. Edge is very important in a competitive exam point of view. This table, please keep in mind. The examples of each edge is also little important, so keep in mind. Another important feature is discharge. Discharge is also very important, especially pseudomonas will have a green discharge due to presence of pseudocyanin. Then the difference between arterial, venous, and trophic ulcers we saw. Yeah, I hope I'm clear. That's